Hello, my name is Craig Sauter. I'm the director of the Blood and Marrow Transplant Program at Cleveland Clinic. I'm here to speak on the role of CAR-modified T cells for B-acute lymphoblastic leukemia in collaboration with AACI. Here are my disclosures. The learning objectives today will include the audience's ability to list current indications for CAR-modified T cell therapy for BALL, for the audience to identify patients with BALL for referral for CAR-modified T cell therapy, to be able to determine timing of when to refer patients with BALL for CAR-modified T cell therapy, and to be able to discuss both pre and post-treatment coordination of care for patients with BALL proceeding to CAR-modified T cell therapy. By way of background, prior to the contemporary era of CAR-modified T cells as well as other targeted agents, dismal outcomes for patients with relapsed refractory BALL were experienced, as indicated by two large studies, including the MRC as well as LALA 94 studies here. As you can see, the vast majority of patients in the relapsed refractory setting experienced mortal demise. Fortunately, in the contemporary era, we have had a burgeoning of development of new agents. So non-CAR T cell therapy for relapsed refractory BALL, there have been two agents that have been FDA approved. Blinatumomab is a CD19/CD3 bispecific T cell engager antibody. That was approved based on a random assignment 2-to-1 randomization study that was reported in the New England Journal of Medicine in 2017 by Dr. Katarjan. As you can see here in the relapsed refractory setting, blinatumomab had superior median overall survival of 7.7 months in contrast to 4 months with standard chemotherapy. This met statistical significance and generated a hazard ratio of 0.71. Inotuzumab, which is a CD22 antibody drug conjugate, was studied in a 1-to-1 randomization, again by Dr. Katarjan, published in 2019. Demonstrating improvement in median overall survival with a hazard ratio of 0.75 and a statistically significant p-value of 0.01. We'll now speak about the evolution of CAR design. Current commercially available CAR-modified T cells for ALL directed against CD19 are second-generation products with either a CD28 or 4-1BB co-stimulatory molecule. There have been many investigators that have been instrumental in development of this second-generation product, including at the University of Pennsylvania, NCI, and Memorial Sloan Kettering Cancer Center. Third-generation products incorporating additional co-stimulatory molecules are in production or are in active investigation at this time. But again, commercially available products have either CD28 or 4-1BB co-stimulatory molecules that are incorporated into the CAR design. Here's a table of the NCCN guideline and indications for both brexacaptogene autoleucel in adult patients, as well as tisagen-like leucel for patients less than 26 years of age, including the pediatric population, for both Ph positive and Ph negative B acute lymphoblastic leukemia. We would highly recommend referral for patients with high-risk features at time of diagnosis, and certainly for patients that fail to achieve a measurable residual disease negative state in first CR. Now I'm going to briefly go through the registrational data for both of the commercially available products. The Eliana study was CTL019, a CD19-directed CAR-modified T cell for the pediatric and AYA population with relapsed refractory B acute lymphoblastic leukemia. Patients aged 3 to 12 years old with BALL had to have greater than or equal to 5% lymphoblastic on study. There could be no isolated extramedullary disease prior to CD19 therapy or prior gene therapy. From 3 years at screening to 21 years at initial diagnosis, patients were able to be screened for study. Fludarabine cyclophosphamide was the standard lymphodepletion on study. Single-dose CTL019 was administered based on patient body weight. The primary endpoint of the study was overall response rate as cumulative CR or CRI within 3 months, assessed centrally. 4 weeks of maintenance remission was required for assessment of efficacy toward the primary endpoint. The secondary endpoints included measurable residual disease status, duration of response, overall survival, pharmacokinetics of the cellular product, as well as safety. Here are the data on the Eliana study that later garnered FDA approval for relapsed refractory B-ALL in patients less than 26 years of age, or less than or equal to 25 years. As you can see, the majority of patients achieved either a CR or CRI. The table on the left demonstrates key treatment emergent adverse events, particularly cytokine release syndrome and neurologic events, or ICANS. So most of the patients did experience CRS. Nearly half had severe CRS grade 3 to 4. Nearly half the patients had a neurologic event, though a small minority actually experienced severe grade 3 neurologic events, and no grade 4 events were observed on study. As you can see, all subsets of patients benefited per the fluorescence plot, and then the Kaplan-Meier plots are on the right, including event-free and overall survival. The median overall survival on study was 19 months, and the median event-free survival was not reached. So with this, the FDA approved usage of lifileucel for relapsed refractory B-ALL, again for patients less than or equal to 25 years of age, and that approval was in 2018. Shifting to the adult population, exclusively adult population, the ZUMA-3 study was KTE-X19. This is a CD28 costimulatory CD19 directed CAR-modified T-cell for adult patients age 18 and over with relapsed refractory B-cell acute lymphoblastic leukemia. To be eligible for study, patients had to have relapsed refractory B-ALL with blasts of greater than 5% in the marrow compartment. This study was unique relative to Eliana in that prior blinatumomab was permitted. Fludarabine and cyclophosphamide were the standard lymphodepletion on study, and then Brexucel or brexacaptagene autoleucel at 1 × 10⁶ was administered per kilogram body weight. The primary endpoint was an efficacy endpoint of CR/CRI by central assessment. Secondary endpoints included MRD negativity, duration of response, relapse-free survival, overall survival, pharmacokinetics of the cellular product, and safety. The median follow-up exceeded 16 months, and Brexucel was successfully manufactured in the majority of patients at 92%, with a relatively short median turnaround time of 13 days from leukapheresis to infusion of the cell product. Here are the primary data on ZUMA-3. 39% of the patients achieved a CR or CRI. The majority of patients achieved MRD negativity. There was a response. Response was similar in all subgroups, including prior blinatumomab as well as inotuzumab. A number of patients proceeded to allo transplant in remission. The median time to allo was approaching 98 days, and 31% of the patients were in an ongoing CR at time of the report of the study by Dr. Shah in Lancet in 2021. Uniquely, ZUMA-3 with a CD28 costimulatory molecule had AEs that encompassed not only CRS in nearly 90% of the patients, with a quarter experiencing severe grade 3 or greater CRS, but also a larger proportion of patients that experienced higher grade ICANS or neurologic events on study. Tocilizumab was provided to the majority of patients, 80%, and steroid was given in 75% on study. Nearly half the patients required vasopressor with severe cytokine release syndrome. Grade 3 infection was observed in 25% of the patients, and 6 patients died secondary to grade 5 adverse events, including 2 that were attributed to the investigational product KTE-X19, 1 cerebral edema and 1 septic shock. So the summary of the studies for CD19-directed CAR-modified T-cells for relapsed refractory B-ALL, including single-center studies, all demonstrate favorable CR rates with variability in event-free and overall survival, although somewhat encouraging. And then toxicity with CRS and ICANS is demonstrated here. Of these studies, the study by Park et al. As well as ZUMA-3, again, are CD28 costimulatory molecule studies. And then Dr. Fry, University of Pennsylvania, and investigators, including Drs. Turtle and Hay at Fred Hutchinson Cancer Research Center, those products were of 4-1BB costimulatory domains. So the real question in patients with relapsed refractory disease, particularly those who are young and fit, is the predominant question is, shall these patients proceed to an allogeneic transplant with curative intent? So in the Memorial Sloan Kettering study on the left, there appeared to be no benefit that was not prescribed by study in terms of patients proceeding to transplant or not transplant. And in a smaller study from University of Pennsylvania, there appeared to be a modest event-free survival benefit as well as a trend towards an overall survival benefit in patients that proceeded to allogeneic transplant in remission following CAR-modified T-cell therapy. So in my mind, this continues to be an open question within the field. Most recently at the Lugano meeting, overall survival per ZUMA-3 responders and subsequent allo transplant was not different compared to those that did not proceed to transplant. So again, this sort of fortifies the question of, with a CD28 costimulatory molecule like the MSK study as well as ZUMA-3, is there benefit to consolidating patients with allogeneic transplant? And I believe that needs to continue to be prospectively and definitively defined in a well-designed study. So here's a summary of studies and the results of allogeneic transplants post-CAR-modified T-cell therapy. And as you can see in tabular form, you're essentially trading improved disease control with allogeneic transplant with risk of toxic effects of allogeneic transplant, including what we refer to as treatment-related or transplant-related mortality. Predictors of response to CAR-modified T-cell therapy is typically related to the amount of tumor on board. So as you can see in the MSK study, patients with higher burden of disease relative to those with lower burden of disease were less likely to have successful outcomes. Another question in the modern era where we have prospective studies where blinatumomab is incorporated earlier in the lines of therapy for BALL is the question of whether targeting CD19 with a bispecific T-cell engager antibody has effects on, or has any deleterious effects on CD19 targeting with CAR-modified T-cells. You can see that this is the report again from the ZUMA-3 study for patients that were previously exposed to blina or those that were not. And it appears that there is some signal towards improved efficacy or durability of overall survival for patients that were blinatumomab naive compared to those that had prior blina. The LA study demonstrated that patients that achieve a measurable residual disease negative state have prognostically improved outcomes, as demonstrated on these Kaplan-Meier plots here, and as published by Dr. Pulsar in Blood Cancer Discovery in 2022. So in conclusion, we in the field, as well as the FDA, has agreed that CAR T-cells are effective in relapsed refractory BALL. Durability clearly remains a question, and the question at the forefront in patients, particularly those who are allogeneic transplant naive, is should these patients be consolidated with intent of cure or reserve transplantation for subsequent remissions, understanding that availability of remission-inducing therapy is limited in this setting. And then in future directions, we're looking forward to an additional product likely to be FDA approved, obacabtagene autoleucel, which will be an additional product available for adult patients with a PDUFA date at the FDA later 2024 and hopefully available in 2025. We continue to work on toxicity risk mitigation and management with therapies such as tocilizumab, steroids, anakinra, and the such. And risk-adapted study designs are needed to clearly define who should proceed to CAR-modified T-cells and at what time point if and when patients should be considered for allogeneic transplant thereafter, largely based around measurable residual disease achievement, as has been studied with initial induction therapy in consideration for transplant for these patients. So with that, it was my pleasure to present these slides. We here at AACI hope you found those helpful, and please feel free to reach out to Haley Honeycutt with feedback, comments, or questions. And I'm happy to take any questions from the group as well. Thank you all.